Good morning. I'm going to discuss the clinical use of opioids in children. I'm going to first just review how opioids work and discuss some commonly used opioids and then review a few case discussions. So opioid analgesics bind to G protein-coupled receptors, and this mimics the actions of endogenous opioid peptides like endorphins. There are several opioid receptor classes, and these receptors are distributed widely throughout the CNS in the periaqueductal gray area, the medulla, the dorsal horn, and also in the periphery. The locations of the opioid receptors throughout the body account for the variable responses when the receptors are activated. So opioid receptors in the limbic system account for the euphoria that can be associated with opioids. The receptors in the substantia gelatinosa and the thalamus are involved in the transmission or the inhibition of transmission of impulses in the spinothalamic tract and the descending inhibitory control. Opioid receptors in the brainstem are involved in meiosis and respiratory depression and cough suppression. And then those in the gut are involved in constipation and gastric stasis. The mu opioid receptor has over 100 polymorphisms and multiple receptor subtypes. And this is thought to influence opioid responsiveness and tolerance and abuse potential. And it's why patients will sometimes say, you know, one opioid works really well for me, but another one I never have an effect with. The receptor subtypes are also involved in the phenomenon of incomplete cross-tolerance. And that is when a patient is on one opioid and probably is tolerant to it, and when you want to switch to a second opioid, you'll need much less of that second opioid. And that's because of this phenomenon where of incomplete cross-tolerance and opioids bind to different receptor subtypes. So how do opioids work? Well, they bind to the G protein-coupled receptor. This changes membrane permeability to potassium and calcium. It hyperpolarizes the membrane, and it inhibits the release of neurotransmitters like glutamate and neuropeptides like substance P. And so when the receptors are activated in the dorsal horn, they inhibit the ascending transmission of impulses through the spinothalamic tract. And they also, when receptors are activated centrally, this activates serotonergic pathways involved in the descending inhibitory pathways that modulate pain response. So opioids generate numerous side effects, and this really complicates their use in acute and chronic pain. The most common side effects are nausea and vomiting and itching and constipation. And many of the side effects can be as distressing to patients as pain. And this is why on our acute inpatient pain service, we really rely on techniques for opioid sparing, and we're very aggressive about the preemptive treatment of opioid side effects. In prospective studies looking at naloxone infusions, low-dose naloxone infusions are shown to be very effective for both itching, the severity and the duration of itching and nausea in pediatric patients. And the studies have shown that there is virtually no reversal of opioid analgesia. Now, bufene is often used for itching, but it's really had very mixed results in kids. Constipation and ileus formation are some of the most persistent opioid side effects. And many agents are used, stimulant laxatives, prokinetics, and these agents don't really target the underlying cause of the GI effects. Methylnaltrexone and alvimipan act as peripherally acting opioid antagonists, and they bind to opioid receptors in the gut. And studies in adult patients have shown fairly good results. There's very limited data in kids. There's one clinical trial of a small number of pediatric patients, but they had very good results, and none of them had reversal of their opioid analgesia. Antihistamines are often used for pruritus. In general, I think they're largely ineffective. I think patients typically fall asleep and they don't realize that they're itchy. There is a interesting novel investigational opioid that uses the concept of ligand biasing. And what that is the opioid binds to the G protein coupled and signaling preferentially that pathway as opposed to the beta-arrestin pathway. And the beta-arrestin pathway is more involved in constipation and respiratory depression. And so these types of new opioid analgesics may offer patients a safer, better tolerated analgesic that may have better efficacy. So when prescribing opioids to patients, it's important to remember and to keep in mind some of the developmental aspects of opioids in infants. Young infants in the first 6 months of life have immature hepatic enzymes, and these are the multiple CYP pathways and glucuronal transferases, and these gradually mature over the first 6 months of life in a variable way. Renal excretion is reduced in the first months of life. Volume of distribution is increased. Brain entry of certain opioids are increased. In addition, infants have immature control over their breathing. They have an altered CO2 response curve and have an increased risk of apnea. They also have, they don't tolerate diaphragmatic fatigue, and they have this greater tendency to collapse their airways. And so it's important to keep all of this in mind when you're dosing opioids in young children, in infants. And so you need to reduce your dose, and you need to have really careful monitoring and vigilance, and try to use, if you can, non-opioid analgesics first. In review of some closed claims among children having tonsillectomies, there were a number of deaths related to the use of opioids. And the biggest offenders were codeine, morphine, fentanyl, and Demerol. And the most common risk factor among all of these was that the patients were probably ultra-rapid metabolizers of these drugs, which I'm going to talk about a little bit more later. Many of them were obese, and they had altered control of breathing, obstructive sleep apnea. Some of the other risk factors were prescription errors and inadequate monitoring and probably premature discharging before they were ready. So there have been a number of case reports among children using codeine after tonsillectomies, and this prompted the FDA recently to come out with a very strong statement about the contraindications using codeine in kids who have had tonsillectomies. But in general, kids with OSA or just even obesity who have the body habitus for OSA have recurrent nighttime hypoxemia, and this probably causes upregulation of their central opioid receptors. It changes their CO2 response curve. They have decreased tone of their upper airways and depressed ventilatory drive, and in the face of opioids, this can further depress their ventilatory response to CO2. So kids that are obese, kids that have obstructive sleep apnea, you have to be really careful in dosing opioids. You have to reduce the dose or increase the dosing interval. And again, try to use opioid-sparing techniques when possible. And all of this is magnified with the concurrent use of opioids and sedatives like benzodiazepines. So I'm very careful to use those drugs in these types of patients. So in prescribing opioids, there are short-acting ones and long-acting ones. So the short-acting ones are typically used for pain that's episodic, kids that have an injury. They take the drug as needed, and then as their condition resolves and their pain resolves, they stop taking the drug. Patients that have more persistent pain that are taking short-acting opioids around the clock are candidates for the addition of a long-acting opioid for better pain control. Most of the long-acting drugs are just reformulations of the short-acting drug in a sustained release preparation. So MS-Contin, which is morphine, OxyContin, which is oxycodone, Duragesic, which is fentanyl in a transdermal patch. And methadone is unique in that it's the only one that's long-acting, but it's an inherent property of the drug rather than just a reformulation of it. So codeine's really fallen out of favor, and for a couple of reasons. Overall, it's a poor analgesic for kids and adults. It causes a lot of nausea and vomiting. It's a prodrug, so it's converted into morphine. So by itself, it's inert. If you are a slow metabolizer of codeine, which is a an immature CYP2D6 pathway. Codeine is essentially inactive, and so it doesn't cause any effect. On the other hand, if you are an ultra-rapid metabolizer, codeine can be metabolized to morphine very quickly, and you have a surge in your serum levels, and this leads to overdose and apnea and death. So oxycodone has really replaced codeine. It has a pretty high bioavailability, 60 to 80%. It's available in a controlled release preparation, OxyContin. And the plasma concentrations peak after about 1 hour with oxycodone, about 3 hours after OxyContin. It's metabolized in the liver. The CYP2D6 pathway is a minor pathway involved. But liver and renal failure can delay elimination. The dose is about 0.1 to 0.15 milligrams per kilo every 4 hours. And I typically try to alternate it with nonsteroidals or Tylenol just for any opioid sparing effect. And for OxyContin, for kids over about 50 kilos or so, the dose is about 10 milligrams every 8 to 12 hours. Hydrocodone is another short-acting opioid. It's commonly prescribed. This is Vicodin, Lortab. It's formulated with acetaminophen, and that's available in a liquid preparation. Ibuprofen, which is only available in pill form. There's very little PK data, though, in children using oxycodone. And it is metabolized in the liver primarily by the CYP2D6 pathway, although that's not the only pathway, but it is metabolized to hydromorphone. So it's a prodrug. And there's a case report in children who have had oxycodone and had a fatal toxic overdose due to the poor CYP2D6 metabolizers. So in my opinion, I don't typically use oxycodone very often. Hydrocodone, did I say hydromorphone? Oh, I'm sorry, hydrocodone. Because of the very little PK data that's available. And since it's metabolized to hydromorphone, to me it makes sense to just prescribe hydromorphone directly. Tramadol is a short-acting analgesic. It has a few different mechanisms of action. It's a reuptake inhibitor of serotonin and norepinephrine, which helps modulate the inhibition of pain, the descending inhibition of pain. It's also a weak mu-opioid agonist. It is metabolized by the CY2D6 pathway, so there can be variability in its metabolism. Nausea is relatively common with tramadol, although it appears to be sort of a pretty weak respiratory depressant, although kids can definitely have some respiratory depression on it. One drawback is that kids receiving tramadol who are on tricyclics or serotonin can have drug interactions, increased risk of seizures and serotonin syndrome. So you have to be careful it seems to be dose dependent, so you have to be careful of dosing and monitor the side effects closely. Methadone is an interesting drug. It's long-acting. It's a mu receptor agonist, and it's thought to have less euphoria associated with it. It's also an NMDA receptor antagonist, so it can help attenuate opioid tolerance. It can be used in the treatment of neuropathic pain, which Dr. Birdie is going to talk a little bit about. One effective methadone is that it can prolong your QT, so you have to keep that in mind when you're prescribing other potentially QT prolonging drugs. There aren't a lot of evidence-based data to know what the recommendations should be for monitoring patients and their risk on methadone. In general, though, it is cheap. It's long-acting. It's available in a liquid form, which makes it applicable for young kids who have chronic pain. The half-life is really variable, 8 to 56 hours, and so. But the duration of analgesia is only like 4 to 8 hours. So you have to be really careful with repeated dosing because it can accumulate and you can get respiratory depression from it. The dose is about 0.05 to 0.1 milligrams per kilo every 8 to 12 hours. And when I prescribe this in outpatients, I tend to not make changes any more than about every 5 to 7 days because of the risk of accumulation. There can be interactions with SSRIs and tricyclics, which can raise serum levels. And there are lots of conversion charts out there in converting other opioids to methadone. And because of this phenomenon of incomplete cross tolerance, you have to be really careful with some of the charts, because I think you need much less methadone, clearly, when you're converting from one opioid to methadone. So fentanyl is, the Duragesic is transdermal fentanyl, where the patch is applied to the skin and a depot of fentanyl forms in the epidermis, and this accounts for the slow onset and the prolonged effect. When the patch is applied, analgesia begins in about 8 hours or so, but it really takes a couple of days, sometimes 3 days, to reach steady state. And by the same token, when you take the patch off, you're going to still have that depot and that prolonged serum level of fentanyl. There have been a number of deaths and lawsuits over the use of Duragesic. Most of these deaths occurred in healthy adolescents and young adults who had Duragesic prescribed for acute pain. Many of them were like dental procedures. And so it is restricted for opioid-tolerant patients. And I have a handful of patients that I use Duragesic patches for in outpatients, but these are only, all of them are for cancer pain patients. So I want to go through a couple of case discussions. The first one is a 9-year-old who presents to your office after being seen in the ED the night before. She fell at school. She has a non-displaced forearm fracture. She was put in a cast, sent home on Tylenol and 5 milligrams of oxycodone. And her mother reports that initially she had very good pain relief, and then over the past 6 or 7 hours, she's been miserable. And she's been taking the oxycodone every 4 hours. So how would you approach this? Do you think this is, do you agree with the pain medication she's getting? Does this seem reasonable? Anyone? So I think that, the dose is about 0.15 milligrams per kilo. I think that seems appropriate. It should provide some pretty good analgesia for this type of condition, a non-displaced forearm fracture. I think it would make sense to add maybe Motrin just to help reduce any inflammation that's contributing to her pain. So the patient, when you examine her, you find that she's holding her arm. She says it's her whole arm that hurts. And you notice that her fingers are cool and they're slightly mottled appearing. So how do you manage her pain in this case? Does this change what you would do? Yeah, so I think that we see this a lot on the inpatient service. Her pain is out of proportion to her injury, and so very frequently we have patients that are post-operative. They have a very stable dose of morphine, very stable level of pain, and then suddenly everything escalates, and it's really a red flag that something is going on, and it requires a good, thorough examination. Clearly, in this case, a cast being too tight is really common. A patient just recently had a missed fracture of her humerus and another part of the arm that wasn't x-rayed. Could also be vascular or nerve injury. All of those things should be taken into consideration. So you were right. She had a cast that was too tight. It was bivalved. Things got better, and she went home. 6 weeks later, she comes back. She had her cast removed. Things went pretty well. She had opioids for a few days, and then pain resolved. And then over the last 2 weeks, her pain has been steadily worsening. And she says it feels weird. It's painful all over. Her mother says she can't even take a shower because it hurts her arm. And now she's starting to use oxycodone again, and they're there for a refill. You notice that, once again, her fingers are cool and there's mottling, similar to when her cast was too tight. So how do you approach this? Do you refill? Do you think opioids are appropriate? Any ideas what might be going on? Could be compartment. What else? Anything else? RSD. So yeah, so the it's unusual at this point to have some of these features. Her skin seems very sensitive. The water hitting her skin causes pain, which is allodynia, which is non-noxious stimuli causing pain. The fact that there's color changes and the skin feels cool are all features possibly of neuropathic pain. Is it appropriate to prescribe opioids? In general, we're taught that neuropathic pain is typically not responsive to opioids. It can be in some circumstances, but in this case, it would probably make more sense to begin physical therapy, emphasize desensitization of the skin, maybe start a neuropathic pain medication like gabapentin, and then refer to a pain clinic if there's no improvement in the next week or two. So another case is an 18-year-old who has an L4 myelodysplasia. She has had chronic back pain due to vertebral collapse, and she's not a surgical candidate. She's non-operative. And over the past year, she's required oxycodone at a stable dose of 5 milligrams several times a day. You see her in your office. She admits to using marijuana a few times a week. She is finishing high school through an online program. She lives with her parents. It's a difficult relationship at home. She asks for a refill for her oxycodone, and you notice that she's not due yet. So how do you handle this? So the prescribing of opioids for chronic pain that's not due to a life-limiting illness is controversial. And attitudes and practices have shifted over the past 30 to 50 years. This has been in response to different clinical data and epidemiologic data and regulatory concerns. And there is uncertainty about prescribing opioids for these groups of patients. And this is in part due to concerns about abuse and abuse potential and addiction. There's also data in adults for the ineffectiveness in treating certain types of chronic pain disorders with opioids, like low back pain. So all of this has led to an uncertainty. But over the past 20 years, opioid prescribing has increased fivefold in the US. And deaths from prescription opioids have paralleled that increase over the past 20 years. Now deaths from prescription opioids exceed deaths from heroin and cocaine combined. Between 1997 and 2006, the sale of oxycodone has increased over 700%, hydrocodone over 200%, and methadone over 1,000%. So this is a slide showing unintentional overdose deaths involving opioid analgesics, and it exceeds both cocaine and heroin in the US. This shows how closely the sale of opioid analgesics parallel this increase in deaths use of prescribed opioids. This slide, it's a bar graph that shows that really the highest group of that have the non-medical use of opioids are the adolescents and young adults, the 12 to 25-year-old group. And this is an interesting slide that looks at unintentional prescribed opioid overdoses, or just unintentional deaths in the US. And you can see that at the end of the slide, in the 2001 to 2004 range, there's an increase, a slow increase in unintentional deaths. And just before that increase is when OxyContin hit the market in the US. So pediatric opioid prescribing has increased about twofold. And prescription opioids are the most rapidly increasing drugs of abuse among adolescents. And it's very hard to predict which patients and which parents might abuse or divert opioids. The decision, I believe, to prescribe opioids in children with non-life-limiting disorders should be an upfront, deliberate decision, rather than kind of evolving over time, and when you look back, you realize it's been a year on opioids. So when it's a deliberate decision, you can have an upfront discussion with the family, with the patient, about the risks, what the goals of treatment are going to be, what the side effects of opioids might be, and then the rules that you're going to set up for adherence. In our practice, we routinely have all patients on chronic opioids sign a contract. It's a contract that they sign and their parents sign. And it provides structure. It provides a set of upfront expectations about what happens if you break the contract. But it's complicated. It's complicated when patients divert. It's complicated by parents who have their own substance abuse problems. And there have been a number of screening tests looking at predictors of risk factors for kids on opioids and other drugs. And the CRAFT is a screening test that's self-administered questionnaire, and it's been validated for kids over the age of 10. And we use that in our pain clinic. And depending on the score, it can guide your plan for treatment and monitoring. So it's a mnemonic, and it's questions like, do your friends or families ever tell you that you should cut down on your drinking or drug use? Or have you ever got into a car while you were using alcohol or drugs? And depending on the score, you're stratified in a certain risk. So low risk would mean evaluating the patients in person every 4 months. Moderate risk is you evaluate them every month. You do urine tox screens twice a year. The high-risk patients and high-risk parents present a problem. It's probably, you should consider referring those patients to a pain clinic, perhaps referring parents to an addiction program. You talk about safeguards at home, locking up the opioids, who's dispensing them, who has access. And it's very good to keep in mind using electronic prescribing so that opioid prescriptions can be tracked, and then using good documentation. So some general guidelines if you decide to use long-term opioid therapy for kids that don't have life-limiting disorders. Regular assessment for safety and effectiveness is key. And effectiveness, for long-term use isn't really pain scores. It's more functional measures. Are they in school? Are they able to do outside activities and social activities? And it's really important to incorporate non-medication therapies into your overall treatment plan. Cognitive behavioral therapy, physical therapy, non-opioid medications whenever you can. And you need to regularly screen for depression, anxiety, other substance abuse. And when do you refer patients to a pain clinic or even an addiction program? Patients who have frequent side effects, patients that are just not getting effective relief on an opioid trial, patients that have a lot of other comorbidities that put them at high risk, and patients who have escalating doses. And then other patients who just have high risk for opioid diversion or abuse. So getting back to our patient who has the myelodysplasia, who's been on a stable opioid dose and then presents with now increasing requirements. One consideration to think of is a phenomenon called opioid-induced hyperalgesia. And this is a phenomenon of nociceptive sensitization caused by opioids. You have increasing pain with increasing opioid doses. And the mechanism isn't entirely clear, but it's thought to involve neuroplastic changes centrally and in the periphery. And it may explain loss of opioid efficacy in some patients. It is probably has the same mechanism as tolerance. It can be hard to differentiate between tolerance. In general, tolerance tends to get better as you increase the dose, and opioid-induced hyperalgesia patients tend to have more pain as you increase the dose, but it's something to consider in these types of situations. So in conclusion, opioids have many uses, acute postoperative pain, cancer pain. The use in chronic pain for non-life-limiting illnesses is controversial. Opioids have risks and side effects. And the prescribing for non-life-limiting conditions should be done with caution, careful follow-up, consideration of patients' functional status, and not just pain scores alone. Thank you.